Welcome to A Real Affliction, BPD, Culture, and Stigma, a podcast devoted to exploring how we experience, treat, write about, advocate for, and conceptualize borderline personality disorder. My name is Cynthia Gralla. I'm a writer and teacher with a history of BPD. Trigger warning, this episode will mention suicide. Today, I'll be sharing the second part of my conversation with Paula Tusiani-Eng, a co-founder of Emotions Matter, a New York-based nonprofit that offers an array of support groups and other resources for people with BPD and their loved ones. But first, I want to highlight the wealth of stigma-free publications on their website, a link to which is included in the episode notes. They offer downloadable guidebooks about BPD facts, finding a therapist, and utilizing single case agreements to access treatment, something which Paula and I talk about in more detail in the following episode. This publication explains how individuals may agitate for their insurance company to cover the cost of BPD treatment, which can be very high in the US because of its time-intensive nature. As a university instructor, I was also heartened by their publication, Supporting Students with BPD, a guide for educational professionals, parents, and students. Paula and I will talk about that one as well. Other guides feature people speaking out about their experience with BPD, which is crucial because research has shown that listening to or reading the personal histories of people with BPD lowers stigma for the disorder. In the second and final part of our interview, Paula and I discuss the present circumstances and look forward to a more hopeful future when it comes to BPD. She criticizes insurance companies in the United States for denying life-saving coverage to people with the disorder and expresses her wish for a more intersectional approach to analyzing its effects, which I second. We need to look at how BPD impacts people of color, Indigenous peoples, people of various genders and sexualities, and people with disabilities. In the episode notes, I also include the article that Paula co-wrote about California granting pre-trial diversion to people with BPD, something we mentioned but didn't explain. This was all my fault. Sometimes I get so excited about the work of my guests that I talk over them. I'm working on that, I promise. Thank you for your patience while I do. I loved the fact that when I attended the peer support groups, they would start out by a facilitator with lived experience, kind of telling their own story. And it's just really nice to hear from someone who knows what it's like and is fighting for their own functional recovery. I think that's really inspiring. I also loved that you have a guide on the website. You have a number of guides that people can look at, can download, and I want to talk about two of them. The first one is this education-related guide called Supporting Students with Borderline Personality Disorder. Can you tell me a little bit about who you worked with to develop that guide?
Yeah, like with all of our resources, we started by parents and people with BPD that were in college were saying like, hey, I don't really know what to ask in terms of accommodations. Like I have BPD and I want to stay in school, but I'm having a hard time educating my professors about like what I need to be able to finish my work or to be a successful student. Mm-hmm. And we realized that there really wasn't anything that actually existed to meet this need. So the first thing we did was we interviewed people with lived experience, either in college or grad school, about how did they get through school? What kinds of accommodations work for them? Because people have done really creative things. Having a room in the school where they can go for 10 minutes, like a very specific period of time, but just to cool off. Or, like sometimes you don't know. I guess I just feel like people who have BPD have been so resilient to get through their education. And the misnomer about BPD is like people with BPD generally, I find, and I don't know if there's any data on this, but generally tend to have very high intelligence, right? Mm-hmm. Which is why there's so much shame, because you can be brilliant. Like my sister was truly brilliant on so many levels, but BPD can really prevent you from functioning on a daily basis.
Yeah.
Getting out of bed, brushing your teeth, grooming, showing up for work, because you don't know on any given day what your emotional range is going to be and what experiences are going to trigger you. And so I think that we know that the data shows that education is really important. You have bright populations of people that staying in school is a protective factor, right? You have structure, you're getting up every day, you're showing up for yourself and others, you're in the social world, you're not isolating or not getting out of bed. So like it's actually a good thing to keep students in school. And so we really created the resource by first interviewing parents and people with the disorder about what helped them so that we can get the raw material. And then we did ask clinicians also to review it for accuracy, but most of that was really created by the community itself. And then, of course, we had designers and things like that that made it look professional. But yeah, it's a great example of how our community knows what it needs and has the power and capability to actually produce publications that help people.
I love everything you said about that. I always found school to give me a structure that I didn't have at home much of the time. So for me, I was lucky I could find that in school. I did see one study. I think it was a pretty small scale study, but it did support the idea that yes, people with BPD have higher than average intelligence. I think in this study, I don't want to get it wrong, but I think the average IQ, average or median was 130, which is definitely above average. But it can be challenging to get through school. And even though I really derived a lot of comfort from school during my compulsory years, university and postgraduate education were still struggles because it wasn't common back then in the 90s, early 2000s to ask for accommodations. So I think that's a really good trend. I definitely recommend to any students or parents out there to look at this guide, to talk to their school. There are things that can be done. And another guide you have is a guide to requesting single case agreements, which I didn't even know what that referred to at first. It's about trying to get your insurance company to cover a kind of treatment that it normally doesn't, which we know even if you can access evidence-based treatments for BPD, even if you find someone, they can be very expensive because they are usually quite time intensive. And as you've said earlier, they require this specialized training. So can you talk a little about the advice there? And also, just more generally, is there a way we can agitate for more insurance companies covering evidence-based treatments for BPD?
So yeah, the single case agreement brochure was really one of our first publications at Emotions Matter. And it came about because, we know that our biggest advocacy issue back then and still today is treatment access. Yeah. Right? Because it's great to have these 5 evidence-based treatments for BPD, but even if you're lucky enough to find a provider, what happens is in the economy in the country in which we live, providers can charge $300 an hour and get that kind of money, right? Because they know that there's a supply and demand problem and that when people need treatment, if they have the resources, they're going to pay for it. And there's not enough if the 6,000 to 1 is correct, then, they're going to find somebody in that 6,000 that will pay. And so, and that's not to say, I understand that's sort of how medicine works. Except that, for other health disorders and mental illnesses, it is covered by insurance. And the difference with BPD is that it's not treated through psychopharmacology, right? Like schizophrenia can be treated with medicine. Bipolar disorder can be treated with medicine. Major depression can be, so you get a script and you see a therapist for a period of time. But, there is lots of funding that comes from drug companies because, I hate to say it, but it's the industrial complex of how these things work. Borderline personality disorder, you could take medicine for some of your symptoms, right? If you're anxious, if you're depressed, So I'm not going to say that medicine doesn't help people. It does, but it does not treat the BPD symptoms specifically. The only thing to treat the BPD symptoms and to retrain the brain to develop new responses to emotional reactions is through long-term intensive therapy. Most of these therapies are long-term, at least 6 months to a year, sometimes 2 to 3 times a week. They involve individual therapy. They involve group therapy. Sometimes it's day treatment. Sometimes it's residential. So the truth is that I'm being very direct, but the truth is that most insurance companies don't want to cover things that are expensive. But I think that's very sad because you have people that their lives can be on the balance. Like if we want to reduce the suicide rate and the overdose rate in this country, we have to recognize that there's a percentage of people that are dying out there because they have untreated BPD. And that nobody is calling it what it is. People are going to the hospital. They're getting sent home from the hospital. They're not getting the care they need. And there have been studies in other countries that show it is cheaper to give people 6 months of DBT than it is to pay for 2 hospitalizations. Right. Mm-hmm. So we're kind of really backward where, we'll pay for the hospital bill, but we won't solve the problem.
Yeah.
Right. And so it's a huge problem because it creates an economic barrier between the haves and the have-nots. And I speak transparently as a white woman that has economic means, and my family had the means to send my sister to facilities. She still died.
Yeah.
But in this country, a lot of people who rely on insurance or Medicaid cannot get this life-saving treatment. And it really does especially affect people of color, Black and brown communities, Indigenous people, and it's not okay. So, we as an organization are trying to get involved with advocacy. Last year, we helped to pass the first piece of legislation in California to address BPD stigma, and that was for prison diversion. So that
I read your article on that, just the brief write-up of it. Sorry to interrupt, but it was exciting.
So I do think that advocacy is possible, but it's going to take more. It's going to take a lot more voices of people that can prove that they are, basically that insurance companies are breaking the law by denying people coverage for life-saving treatment. And we're going to have to collect the evidence. I'm not sure if it would be a class action lawsuit or if it would be like what we're doing now is trying to research different states and looking at the Medicaid reimbursement rates. And some states have DBT that is reimbursable at high rates or market rate, and other states, it's very poorly reimbursed. So we're looking at different strategies, but I do think it's vitally important for people that if you have BPD and you have been discriminated against by a health insurance company, don't take that. I mean, I know when you're hurting and you need care, you can't fight these battles, but please be in touch with us because we want to hear your story. If we can't gather sort of grassroots population level data around the real experiences that people have with insurance companies, it's hard to sort of fight insurance companies and to change the system or the access points. Why do we have single case agreements? I didn't answer that question. So when you can't get something covered by your insurance company, you can issue what's called a single case claim if you show that there's nobody in your 40-mile radius that treats BPD and that you need this very specific treatment. You show that you have a BPD diagnosis and that you need one of these 5 treatments, and there is a provider that provides this treatment, but there's no one else in your plan that does. You can file this single case. And there's a lot of people that have had success getting fully covered treatment by appealing through these special appeals processes. So we created that guide to help people have the language because you know what it's like to call the insurance company. You get bounced around from person to person to person. And sometimes you need to have the codes and you need to have the lingo and the language. And so that's what that resource is.
Yeah, that's fantastic. I think it's so good that you have that up there. I'm so glad you invited people to reach out if they've been discriminated against. And you basically answered 2 of the questions I was going to ask next. One was, what is the biggest challenge in terms of BPD? And it sounds like it is this access to treatment. And I was also going to ask about your awareness and advocacy work, but maybe you could say a little more about the advocacy in terms of how other people could get involved and support Emotions Matter. Are there people to write to? Are there fundraising events to go to? Anything that could help?
Yeah, thank you, Cynthia. I mean, we're a very small nonprofit organization, and we're really run by volunteers. We have roughly 65 to 100 volunteers around the country that help us do the work to live out our mission to help support recovery. Mm-hmm. And, advocacy is hard work. It's long term. And we live in a really fractured healthcare system, because as opposed to countries abroad where they may have more centralized healthcare, or they're smaller countries, in the United States, other than Medicaid and Medicare, which then gets funneled to the states, most states have certain private insurers. And so healthcare is regulated by the states, not really by the federal government, which makes it really difficult. Like as an example, when Autism Speaks, which is an advocacy organization for autism research and advocacy, started their movement to get ABA therapy covered by insurance, they went state by state and put grassroots campaigns together to enact legislation in each state to get ABA therapy covered. So, we're going to have to decide, do we have to do that for BPD? Do we have to go state by state and introduce new legislation to try to get treatments covered? Because it really is against the law. There is a federal parity act that says that mental health care has to be covered with the same parity as physical health care. And I do believe it is not just an injustice. It's like, I do believe, and I can say this transparently as a survivor, because I've been going to the cemetery to visit my sister for 25 years, that like people are dying because they can't get care. I know people that have died by suicide waiting on waiting lists. It's not okay. And it can never be okay until people are not dying anymore. So I would just say that if you are interested in getting involved, yes, absolutely. Get involved in our organization. There's other organizations out there that are doing advocacy work as well, like our partners, NEA, BPD, and TARA, and other organizations. We all want the same thing, which is treatment access. And we ultimately all want people to get what they need to get better.
Yeah, absolutely. I love your passion about it. I agree. Even in Canada, where I now live, there are a lot of issues with access, because depending on the province that you live in, mental health care might not be covered beyond psychiatry visit. And that's the case in BC, where I am. And a lot of people do have extended medical through their employer. And then if you have that, then mental health care, long-term therapy would be covered. But there's a doctor shortage in BC. So there's so many problems compounding these issues of access. And as you say, this is one reason why people are dying and why that suicide rate isn't really budging. Is there something you're particularly proud of in terms of what Emotions Matter has accomplished?
I'm proud of so much. I mean, I would say that, I'm really proud that we are a peer-led organization. Everyone in our organization has some connection to BPD, but our organization is, even our board of directors, people have lived experience, and it's a majority of our board and our volunteers all have lived experience. And I'm really proud of that because, again, this shows you how much the field has changed in 20 or 25 years. That, when my sister first passed away and I started to learn about people in the BPD space and meet doctors, the stigma was worse than it was today. Mm-hmm. And there's a lot of misperceptions like, oh, well, people with BPD, they can't be in support groups. It's too risky. Oh, what are people going to do? Like talk about suicide all day? That's not safe. Or there was a lot of really stigmatized views about whether peer support could even happen. And I guess because, again, as I explained earlier, everything that I know about BPD is through the lens of my sister, who I loved, and I didn't really pathologize her. I just saw her as having a part of her brain that wasn't working, and it affected her behavior. And I always knew there was a person there beneath this thing that she was suffering from, just like how somebody could have lupus or diabetes, or, you have something, but that's not all of you. So I think for me, it was always really important for this to be, and this gets back to sort of my my sort of approach and career is about building organizations from below, grassroots organizations that have a real empowering framework to give people a voice and more self-agency. And so I remember telling a lot of the doctors, hey, when people go to an AA meeting, no one's worried about someone ODing in the parking lot. They're allowed to have meetings. Why can't people who have suicidal thoughts be in a room together and talk to each other and get social support over those very real and frightening experiences and not feel judged for it? So we figured it out. We have a lot. You've been in the groups. We have a lot of guidelines. People have to sign waivers. But what we've shown is by setting expectations about what it is to have a supportive community, people follow the guidelines. We never have any issues. It's actually really beautiful, and it turns stigma on its head because it shows that people with BPD can be in community and they thrive in being in validating, supportive community environments. It's when people are not supported, they're in invalidating environments where they're feeling constantly rejected. That's when they're not sometimes at their best. But in our community, we have no problem because we set people up for a really, I think we try to set people up with a really positive experience, right? Where we don't judge, we're very warm and welcoming and accepting, and it's all about the lived experience. And our focus is on recovery. We want people to come to our groups and leave feeling better, leave feeling a little more hopeful, even though usually people are coming to a group because they've had a hard day. We want people to leave feeling better. So I think I'm really most proud of founding, the only peer-led BPD model in the United States. And there are lots of other kind of podcasts and groups and things like that are out there now. But in terms of support groups, I'm super proud of that.
I have one final question, which is, how would you like the conversation about BPD to change in the near future? What revisions in how we conceptualize or talk about BPD might be helpful for supporting the community?
Yeah, other than, the advocacy pieces, which obviously I'm very passionate about, I'd like to see some of the research literature shift to think about some of the social determinants of health and some of the economic variables that are impacting the advocacy issues, because we don't have very good economic studies in the United States about cost of treatment and understanding what the consequences are of untreated BPD, such as homelessness, housing insecurity, the incarceration rate. I think there's a lot of other social problems that are caused by not treating BPD, but we don't have good research about it because so much of the research is dictated by the scientific community that's looking at either interventions or the neurobiology. And I understand it's so important to be in the race to find the drug or to find the intervention that works. But I really believe that I want studies that are going to help people in the here or now get the help they need. I don't want something that's going to help people 10 years from now, because people are dying today. And I would love to see more research that really takes the lived experience perspective in account. Recovery is a relatively new phenomenon. As I said, it's only since the mid-2000s that many of the treatments today have really been available. So maybe it's 20 years roughly. No, not even, it's probably less, that we have people that are in recovery. That's why in the last 5 years, you see podcasts like this. People are now able to get to a place where they're able to be freer about talking about it. And the stigma is not what it was. And this is it's really only in the last 5 years where there's been an explosion of bloggers and people on Twitter and Instagram that are all of a sudden talking about BPD. And I think that there's a lot more openness than there used to be. And it's really imperative that the research around the lived experience catches up. So we start to understand what recovery really looks like, because the science around recovery is, you're recovered if you can have a relationship, or you're recovered if you have a job. Well, if you ask people with BPD what recovery looks like to them, they're not going to necessarily say those two things. I do think that some of the research reflects, it's not just stigma, but it's like a doctor's perspective, but it doesn't always reflect the perspective of the person living with the disorder. And I think people living with the disorder want to have so much knowledge about things that really matter to them around the internal symptoms, the internal incoherent sense of self, around favorite person and attachment. There's so many things that people with BPD just don't understand because it's also not in really very easy to understand language. You know, the criteria of the DSM is in this really psychological terms that are really frightening to the person with BPD, and they're even hard to understand. Like, what does that mean? I don't have a coherent sense of self. So I think we need to do so much re-education, and we need to include people with BPD in the conversation so that we can really create a culture and an environment where researchers and doctors and people with the disorder and family members are working together to really support at recovery.
I'd like to thank Paula Tusiani-Eng for her time and the whole team at Emotions Matter for the incredible work that they do. Please come back on September 15th for the first part of my interview with Nina Shope, the award-winning author of Asylum, a historical novel about hysteria, a mental health diagnosis that shared some affinities with BPD.